Hey, everybody. Welcome and to our third podcast. And this podcast is dedicated in memory of my brother, Tom Nacella, who was a big part of the Medama program. And he's the one that came up with the Medama Miracle, which is what this program really is. And you'll learn more from everybody here. So, Alex, take it away.
Well, thank you very much, Mike. Want to introduce our guest for today, which is Darryl Patterson. Know Darryl for many, many years. I'm out here in Chicago in a quiet booth in the Delta Lounge, hoping that no one interrupts me. So excuse the color and the picture and the lighting, but that's where I am. Uh, Sometimes you're on the road and you have to do the podcast from wherever you can. So, on that note, I want to introduce Darryl Patterson. I think the best person to introduce Darryl is Ronnie. Ronnie's been working with Darryl longer than I have, as long as I've been working with Darryl. And so, Ronnie, why don't you introduce Darryl and at the same time read a letter that I think we can start the conversation going with today's podcast.
Okay, thank you. Hello, everyone, and welcome also to the podcast. And we're going to welcome Darryl Patterson. And Darryl and I have been working together for many years, and he's been great to work with. He's a wealth of knowledge. I'm going to let him tell a little bit more about himself and his background, but he is a wealth of knowledge as it comes to infection control and to environmental services. So, and what we're going to be talking about today is a letter that was written by Dr. Jop from APIC, the CEO from APIC, and we're going to be talking about his letter and the confusion about IFUs. But before we get into that, Darryl, I'd like for you to tell a little bit more about yourself.
Thanks, Ronnie. Alex, great team of guys to work with here. Presently I'm the president of manufacturing and healthcare for ACE Capital, which is the parent company for Medama. And we are excited to be working still in the healthcare industry. I've spent many, many, many years in healthcare facilities, EVS director in several hospitals, been in it a long time and have seen all of the issues and problems. And, you know, a lot of people think you go into a big hospital, you got all these problems. And I've always said, doesn't matter what size of hospital it is, they have the same problems whether 1,000 bed hospital or 100 bed hospital. The same problems, the very same problems exist. And one of the things that's been a concern for IPs and hospitals, particularly over the last few years, is IFUs and how they're structured and how difficult it is to understand those IFUs. And I want Ronnie to go ahead and read a little bit from this letter because I think this, if this gets through to the Joint Commission, I think it's really going to be a value and a help to
Darryl,
all the IPs in the
yeah,
end.
before Ronnie reads it, just for the people out there that don't necessarily know what an IFU is, you want to just
Yeah, good, good,
Yep,
good
yep.
point.
yeah.
It's an
I was thinking
information.
about you, Mike. Yeah, I was
Yeah.
thinking about you specifically. I didn't want to say it, but go
Yeah,
ahead.
it's an information for use document that is put out by the manufacturer of equipment, and what it is for is to tell the individuals who are in hospitals, people who are responsible for cleaning and disinfecting this equipment, what that process is and what it should be. And it's really designed around maintaining the warranty for the manufacturer and is not really put together, and the information is not provided that really helps or informs the IPs and the EVS directors. It says, okay, do this, clean it this way, clean it that way. But then they go into products, and that's one of the main things I want to talk about today is different disinfectants and the issues that IPs have on saying, what can we use on this? And so I'll let Ronnie read a little bit of that, and we can come back and then discuss those issues.
Okay. Dr. Jop, he actually made a post on LinkedIn and he really kind of summarized his 2-page letter that he sent to the Joint Commission. He summed it up very good. So I'm just going to read his post off of the link off LinkedIn. And he says, to our colleagues at the Joint Commission, we need your help. APIC, the Association of Professionals in Infection Control and Epidemiology, on behalf of our 15,000 members, officially requests this week 2 modifications to the Joint Commission's approach to assessing instructions for use, or IFUs, compliance during surveys to assure that everyone's efforts are focused on keeping patients and healthcare environments safe. First, APIC requests that a differentiation be made between simple non-compliance with policy or stated practice and commonly used approach where facility has conducted a risk assessment and determined that an alternative cleaning, disinfection, and or sterilization method is appropriate. Second, APIC recommends that IFU related findings no longer be assessed under the Infection Prevention and Control chapter of the Joint Commission standards, and instead be housed either under Environment of Care or Leadership. The Joint Commission can make a difference here. APIC and our members stand ready to assist. And this letter is a 2-page letter that was released in May or sent in May of 2025. So it's just a few months prior is
So,
when
so
Dr. Jop sent this letter to
Ronnie, so
the.
in English, how would you sum that up in like 2 sentences?
Well, basically, what they're saying that in the 2-page letter really goes into it in detail. But when you get to looking at IFUs, if you can find them, that's one problem is that not all manufacturers readily available IFUs. So, and if you go looking for them, sometimes you're having difficulty finding them. The second thing is if you can find them, they're difficult to understand. They're not written in plain English, and there's some confusion related to what they want done with it. Like for instance, and Darryl's going to get into this more, but the type of chemistry used to clean or disinfect. And it does not sometimes take into account that that chemistry may be good for the product. However, it may be ineffective against the organisms that you're trying to kill that have come in contact with this piece of equipment within the hospital. So it
Right.
increases the risk for patients that down the line that may be coming in contact with this manufacturer's item. It increases their risk of infection because it
Well, let
hasn't
me
been properly disinfected.
well, let me
And
ask you and Darryl before even go forward to all the technical end of this. But if I'm a hospital and I own a bed or I own a piece of equipment, why should anyone care whether or not I decide to destroy that piece of equipment using a disinfectant? Like you're saying, the most important thing is the health of the patient. So who has a right to dictate to me, especially a lot of these beds are no longer under warranty anyway. Some of these beds are 10 years old or more. So why should anyone care, or why should Joint Commission? Why does this letter have to be written to Joint Commission? What role does Joint Commission have in deciding whether I'm destroying my beds or not?
Well, that's
well,
that's a two-way street there. One thing, a lot of hospitals don't buy beds. Number one, they have some type of a leasing agreement. It's not really but it is a leasing agreement to where they pay X, and these beds are brought in by the manufacturer, and they're still under a quote warranty. So you don't have hospitals. More modern times, we used to buy all of our beds in the past, but now a lot of hospitals lease these beds because they find it a more favorable way of keeping newer beds, rotating beds out, bringing newer beds in. And but manufacturers don't design this equipment a lot of times to stand up to a 2 and 3 time cleaning a day of a piece of equipment. materials are not conducive to that. They use sometimes subpar material because it's cheaper to build it that way. So there's a lot of different things that goes into how how that process works there. I believe Ronnie was going to say something.
Yeah, well, one of the things of the Joint Commission, their job is to make sure that things are being conducted within hospitals that don't place patients at increased risk. They're wanting to make sure that a certain standard of care is maintained and upheld within the hospital. And so that's part of their process for looking at this, at all. They don't really, I don't think they care so much about the condition of the equipment as long as it's not impacting patient care.
Well, how should it impact the patient? If I'm using a disinfectant or a chemical that's going to break down the bed, how does that impact patient care? I mean, I'll
Well, if
replace the bed I mean, I can see them coming after me or coming after a hospital if the bed is in bad condition. But if the bed is still holding up, it just may break down quicker and I may need to replace it. Why does Joint Commission even care in the first place? I mean, I really understand this APIC letter because in a way, what in the world is Joint Commission doing by all of a sudden deciding to, make out what I'm going to use on the bed or not?
Well,
what
one of the things there is the quality of the bed itself and how that when you clean with certain disinfectants because of whatever that pH may be, a very high pH, for instance, like bleach. Bleach is a very high pH. When you begin to wear that surface down, eliminate that surface, that premier coating that they put on these plastics and those things, you don't see it with a naked eye, but that becomes a harbor
yeah.
for bacteria. Bacteria can get embedded into there. So that's why it's real important too. I mean, you can say, well, they bought the bed. Who cares what it looks like? But it's the quality of the bed, how it looks, and if it has been cleaned and cleaned. I mean, you're talking about cleaning something continuously, 365 days out of the year. You're going to stress that material. And when that material, particularly, let's talk about like the mattress, that's a big concern is those
Yeah.
mattresses because the quality of that material on those mattresses don't stand up to these heavy chemicals used day in and day out. And then when you begin to get bad places or scars or all of those different things in bed, it becomes a place to harbor bacteria. Ronnie can explain that a little better than I can, probably.
Well, even if it is eroded to a point that it's no longer impervious. So then you've got things like urine or body fluids that could be secreted, that's going to be, like, for instance, if you start an IV on a patient and the blood gets on the mattress and the mattress is no longer impervious, now it's going down into the foam portion or the inner portion of the mattress and it may come out with the next patient. So it's increased in patients' risk. Those surfaces, when they're not at their best integrity, then that does increase for risk of transmission of infection and potential bloodborne pathogens.
Interesting. Mike, any input on your part on this? Any
Well, the
questions?
only thing I'm thinking is I'm hearing well, you're talking about beds, but you're really talking about all the equipment, right?
Correct.
Yes.
Yeah, everything. So I would think there's a point probably where the manufacturers have covered some of this in newer equipment. I would think probably maybe the standards are more there. Maybe I don't know, but Ronnie, you said they're trying to come up with something that's a standard that'll cover everything.
Well, within hospitals, whenever more than one hospital, they are doing things a certain way that maybe is a little different than the way it's been done. As more and more hospitals adopt that, it becomes a standard of care. It's kind of an unwritten rule, if you would, in healthcare.
Yeah,
Um,
like I know, like in the beds I've seen in some of the hospitals, they have these touch, but like buttons. I could see those things collecting bacteria and like wearing
yeah.
out. They wear out like things
Yes.
like that. So I
Anywhere
guess
that's on the
yeah,
surface.
anything where there's touch, I think, is really got to be the main focus, and then how that is affected with electronics, I guess. If
Yeah.
it if it's circuitry or whatever.
Well, and you got to remember those high touch surfaces in the patient room are going to be, those are the surfaces that we're asking EVS, we're asking nursing to continually wipe those areas
Wipe those
down
down.
because
Right.
those are at greatest risk and probably most contaminated within the patient room.
Well, I'm wondering if on Mike's note, if you're having a uh, touch, those buttons on the side of the bed, does Joint Commission come in and examine to see if they're worn? I mean, they're so concerned about what you're cleaning. Are they going to sit there and inspect the beds to make sure that the beds are not, those buttons aren't worn, where they could be harvesting bacteria or harborers of bacteria because of the wear and tear? Is that
A
something
lot,
that you
a
know?
life safety joint commission person might go around checking those things. I mean, they look at those different items. If you're messing with items that got an electrical output, they may be visualizing some of that. I mean, you never know with joint commission what their focus is going to be. I mean, they can change their focus a lot of times. And but I think the real issue for IPs aren't necessarily about the cleaning, it's what they're being cleaned with. Because, for instance, I won't name the bed manufacturer, but there's a bed manufacturer that has a list of disinfectants and they name them by name. I mean, they give the name of the product, the brand name. They also say there's a lot of different language in there. And sometimes what the problem is, Alex, is you have to dig into this IFU to really get answers. Well, IP people don't have time to sit down and read 25 pages. You know what I'm saying? Of an IFU to find out that, oh, it mentioned cleaning here, but it also mentioned it at page 47 in a very small blurb. They may state in page 47 chemicals you can't use. I mean, they'll name it right. And a lot of the IFUs aren't written. Here's the real confusion: they're not written around brand name products. They give an example of a brand name product that you can use, Clorox bleach wipes, let's say, and but they also go over to the other side of that and they give the chemistry. Here's the chemistry of that product. And if you read on down into the IFU, you really read down further, you take the time and read it, it will say that products that are similar, products that are of this chemistry can be used. But nobody goes that far. It only said Clorox bleach white, that's all we're going to use. But that's not really what all the IFUs say. And they're not clear with that language either. And that's where a lot of confusion comes in for the IPs and the EVS directors when they're looking, what can I use? Can I use my product? And then a lot of them are under the assumption I can only use Octavir 1. What else is amazing about that is those chemicals they're putting on there, they're doing that to protect their product, whatever it might
Right.
be. They're not putting it on there for the safety and health of the patient because guess what? There's a lot of patients lay in these beds. That is the nest for C. diff. That
Well,
is your nest in
but
your room.
that to me is the mystery here because if you're having a patient in the bed, Joint Commission is looking at what's good for the bed in order to kill the bacteria, but a lot of these chemicals are not safe for patients. There are chemicals out there that are parasitic acid, for example. I can't imagine laying in a bed that was cleaned with parasitic acid is good for you, especially if there's residual left behind. I don't know how recently the parasitic acid was applied to a bed and now a patient is lying in the middle of it. Who knows what kind of rash that causes? What about bleach even? How toxic is bleach on your skin or quats, which are poisons, and they're lying around your bed and patients are touching it and putting it into their mouths and maybe it's getting their food. You would think if Joint Commission is going to be concerned about, the proper cleaning of the bed in the sense that the chemicals safe for the bed, what about the patient? Aren't we concerned that the chemicals safe for the patient?
Exactly. Or is that product that they're listing on their IFU doesn't even kill C. diff?
Right.
Doesn't even kill Cioris, doesn't even kill certain bad bugs in the hospital, but they're not They're not putting, they don't care. They really don't
Right.
care. They care about their equipment not getting damaged. That's what they care about
So,
because they want that warranty to stay intact.
But that doesn't make any sense. The whole thing, and I understand where this infection control person, the APEC, what's her name? The person who wrote this letter?
The doctor.
Uh,
doctor,
doctor. It
Yeah,
was a doctor.
yeah. The
Doctor.
Dr. Devin Job.
Well, Dr. Devin makes sense because to me, it's so unreasonable and such a unfair position for Joint Commission to come in and start deciding what chemicals are proper for using for beds. I mean, if you're going to start going that route, then Joint Commission should really look at what's most important, which is the health of the patient, not the health of the bed.
Well, you
I
just you,
mean,
you just said a mouthful because Joint Commission doesn't do that. Everybody thinks Joint Commission says you have to read the IFU and can you only use those products listed on the IFU. That's not what the Joint Commission says at all. What the Joint Commission wants to make sure that they're doing is processing that bed like it needs to be processed, cleaned, disinfected in a proper way, not the product you're using. Joint Commission has no oversight on what products are used, or nor can they dictate, and they don't want to dictate. But they do want you to make sure that you're cleaning it in a proper manner, that you're removing all the bacteria you possibly can remove, and you're doing the process correctly. And that's where, when Joint Commission comes in, there's some confusion with that with IP, and I think there's some confusion with it with some of the Joint Commission inspectors when they come in. Is they don't. It says in their own documents, they don't dictate what product you use. They say it in their own. You go into their book because they got a big book, and you read their book. They don't dictate to you. They just says, okay, if you get a new product and it's not on the list, you need to do a surveillance, run a small check, run it for a few days, see if it does any damage. But they don't dictate and tell you you can only use the products listed on that list. And most manufacturers don't have the time nor the money, nor do they want to spend the money to verify every product that's available. They're not going to do that. You call them up.
not
I
only that,
before I called them. Hey, can you test my product, man? We can't do that. We
well,
just don't.
I would take it one step further. I mean, I would think a manufacturer would be nervous because if they're selling millions and millions of dollars of beds, the last thing they want to be able to, or the last thing they want to tell a customer is you can't use XYZ chemicals to disinfect our beds. And meantime, that's what the hospital is using and what IP wants them to use. And by you telling them not to, they may go to another manufacturer and buy beds from someone else
Well,
because of
that'll
your
happen.
limitation.
is it
Yeah,
possible?
so
Yeah.
they probably want to stay away from that whole discussion in the first place.
Yeah, it's really a confusing. I think I can't remember Ronnie what verbiage he used, but it is absolutely a very contradictive conversation when it comes to hospitals and IFUs, and the confusion needs to be cleared up. And it is on the manufacturer because they're laying out the guidelines, and so the IPs are expected to understand the guidelines, and none of them are clear. None of that is clear. It's very very confusing, and then you call them up. Oh, yeah, that product's fine. You know what I'm saying? But who has time to surveil all that and do all that? They
I'll
need
take
to
it one
be
step
clear.
further. Yeah, I'll take it one step further, Darryl. And Ronnie, tell me if this makes sense. If you're coming in a joint commission and you're telling people what's the IFU that you're following, cleaning these beds, then all of a sudden, infection control nurses are no longer concerned about getting the best disinfectant, but they're looking for the patient, that is, or for the environment. They're looking for the
Exactly.
best. They're looking for the best disinfectant for the bed.
Well, and I think
Instead
that's
Exactly.
of
That's my
that's
point.
and I think that's part of the
yeah,
reason that APIC is wanting this survey or the IFUs, if you have a finding, for it to be under environment of care or leadership, not under
right.
infection prevention.
Right, because infection prevention wants to get the best disinfectant to getting rid of the bacteria and virus in the environment. What's the best to kill C. diff or Candida auris or whatever the emerging virus of flavor of the month is? Not what's safe on the bed, right?
Correct.
They want to know, are they protecting the staff and patients and visitors from all these crazy organisms? And now all of a sudden they are worried about warranties. And matter of fact, when they make a decision on what disinfectant a hospital is going to be using, it's no longer, is this the best disinfectant? The question is, how is this on my equipment? Which is a little bit ridiculous, right?
Yep.
Mike, is this ridiculous, Mike? It was just me.
No, no. I mean, the whole thing. I mean, I don't know. I don't know. I'm trying to understand what's.
Yeah, it's
It
it's
sounds
a
to
very
me like there needs to be somebody in the hospital that goes around inspecting. It sounds like. I mean, it's the problems dollar wise. Must know how much loss they have, right? I mean,
So then why? So that's the whole thing.
dude,
Look, if I'm a hospital and I'm taking care of patients,
right?
and there's a hospital in New York City. There was actually a New York Times article on this hospital. Don't want to mention publication.
right.
They had a article about $1 million+ a year the hospital throws out of equipment that is damaged because of bleach. They use Clorox bleach. I don't know if it was Clorox bleach, but it was bleach. And they bleached everything to the point where they have to replace all this equipment. And they interviewed the infection control director at that time. This is going back a couple of years. And he said, look, our number one concern is the patients and, their health. So we need to do whatever possible to make sure that the bacteria and viruses that are threatening the lives of our patients and staff are going to be eliminated. Now, that takes a secondary step. That becomes not as important as, is the furniture, is the beds, is the machinery that I'm using, are the policies that the manufacturer of this equipment dictate being followed? Which means I may have a disinfectant that's not as great as disinfectant A. It's only disinfectant B, but it's better for my equipment. So rather than going for disinfectant A, which is going to guarantee the health of my patients, I'm going to go with B because I want to make sure my equipment is okay. So to me, that's a warped, upside down universe. It's almost like the surgeon who says, as he's operating on the patient, I'm going to use a less quality scalpel because I don't want to, mess up the sterilization machine.
Yeah,
So
right. Instead of worrying about what you're doing for the
ex-
patient. Yeah, it doesn't.
exactly. Instead of worrying about the patient, I'm more concerned about the sterilization machine than I am concerned about. Now, the scalpel A may guarantee the complete removal of the tumor, and scalpel B may not. The scalpel B is going to survive my steam sterilization machine, while scalpel A may not. I mean, it's so ridiculous. There's something we're missing here. Something
Well,
doesn't
they
add
must
up.
have average periods of time to how long the equipment's supposed to last. I mean, they do that with everything, right?
Yeah, but
And I,
but that's
But
a
it's
cost
but it's
running
not.
a business.
Let's say it's 10 years and they're getting five. Well, obviously there's a problem, right?
Well,
right.
yeah, well, there is a
Is
problem
that so? That's what
financially.
they're finding, that some equipment's breaking is going out sooner than
I,
it's
I, I don't
going to be
know.
all the
To me,
same.
it sounds like almost like they're worried about the warranty, or that maybe they're worried about, like,
Well,
like
the cost of
Ronnie
the
and
equipment
Darryl.
is getting to them, I'm sure. And if it's supposed to
Yeah,
last 10 years and it's lasting five,
but Ronnie and Darryl said, well, the problem is that you're going to break down the equipment and then you won't be able to disinfect it properly. Now, if a hospital says, screw that, my most important thing is the patient. So I'll throw out the bed or replace the bed when it starts to get to the point where I can't do an efficient disinfecting. Why in the world is Joint Commission caring what I use on that bed to the point where now Darryl and I and Ronnie, when we go to customers out in the industry, the number one thing that nurses will mention is, "Oh, does this meet the IFU of the bed?" My first question would be, "Does
Does
this
it
meet
meet your infection
the
control
control
policy?
yeah,
pod?"
right,
Yeah,
right.
I mean, to me, all of a sudden the bed became the patient.
Yeah.
Well, who's teaching that the IFUs are so important? Who's the one that's teaching that to these nurses?
Well, that's
Can you help
being
us with
pushed
that?
by the
Yeah.
Joint Commission when they come in and do their survey. They're looking to see that whenever you are disinfecting and cleaning equipment or sterilizing, even that you are following the manufacturer's instructions for use.
So they come in, how
Right.
often do they come in and inspect? Once a year or something? Or
Once every 3 years, uh, generally is the time frame.
and the inspecting that they do can tell them enough to handle what we're talking about?
Well, they come in with a broad brush and they look at almost every facet within the hospital. They come in with a team, and they're usually there for a few days, depending on the size of the hospital and the length of time it takes to do the survey for the hospital. And they're pretty deep. They do a deep dive and they look at everything, every department. They try to leave no stones unturned, if you will. And then they take and they write up their findings. And sometimes, if they see one thing, it could be a fluke, and sometimes you'll get a surveyor that realizes that. But if you start seeing a pattern, almost every surveyor is going to make a note of that. So if they see that you're not following IFUs, then it's going to be a hit for infection control right now. And so, of course, APIC is also asking that it fall under leadership or fall under the environment of care. Um,
Or
because,
should they
like you
be
said,
inspecting more often? Should they be inspecting more than, or should they have somebody on staff at the hospital that's inspecting all the time?
Well,
I mean,
well,
millions of dollars being lost. I
yeah.
mean, how much does it cost to put somebody on that has a background that could look at this all the time, writing
Well,
up
let me ask
reports?
you. Let me ask you a question. I mean, this well, let me not ask you a question. Let me make an analysis on this. If you're in a hospital, Mike, and you are in bed, and your number one concern is an infection, would you prefer that a hospital go with a decision on what disinfectant they're using when it comes to your safety, or is your
Or the bed
number
that I'm
one
in?
concern the bed safety that you're in? Apparently, the
Me,
bed
me.
is okay. So there you
No
go.
brainer.
Apparently, Joint Commission and a lot of these infection control nurses are more concerned about your bed
I
than
know, I
you.
know. That's a problem right there. That right
So
well,
forget about the millions of dollars. Oh, Ronnie's here to defend infection control nurses. Go
as
right.
an
ahead.
infection control nurse, I have to say we are very much concerned with the condition of the bed, and likewise,
Right.
I wouldn't want to be in a shoddy bed either.
Oh, it's true. You
But
don't
we're
Right.
want to be in a
also
dirty bed.
concerned about the environment and the potential microorganisms that are there that increase the risk of infection for the patient. So we are concerned about both.
Then I
But
think
wouldn't you
somebody on
prefer?
staff, they should have somebody on staff
But
then.
but 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 Joint Commission's deep dive is more about the patient than the bed, is it not?
So let me try to explain that too. What they're looking for documentation more than anything. When they come in and do this, they're looking for documentation that you have trained the people on proper procedure for cleaning that bed. You have all this documentation. You have documentation on what product they probably want to say, what product are you using, because they always want to look at your labeled product. uh I don't believe I've ever experienced in my whole time, Ronnie, you correct me if I'm wrong, I've never experienced anybody from Joint Commission ever going and surveying the bed itself. I've never really seen that. They may be looking out of the corner of their eye, they may be looking for those small things, but to go and say, all right, what product are you using? Now let me go see what the bed looks like. I've never seen that.
Yeah.
It's they want to make sure your documentation, that you have documentation that the EVS people have been trained in the proper procedure for whatever product you're using. Literally, Joint Commission don't care about the product. That's where the confusion piece is coming
Yeah.
in, because all the IPs are assuming that if the IFU says you have to, oh, here's a list of products, you have to use these. That's where the confusion comes in, because most of the IFUs will, if you read enough, but who they don't have time to do this. They're trying to care for patients. But if you read enough in the IFU, you can find that information. The problem is the manufacturers are not putting this information together in a cohesive format that can be read, understood, and all the documents in one place. And the reason they don't do that, that's called self-protection.
Yeah.
They hoping you use something else and mess their warranty up. They don't care. You know what I'm saying? But
Yeah.
a hospital should say, what is your IFU? What can be used on this bed? If it comes to me and says, well, you can only use this and it doesn't kill C. diff, they ought to be sent out the door
100%.
immediately.
It seems like the furniture is dictating to infection control again
Yeah.
what it is to use. In other words, if I was a hospital and I was and by the way, I gotta put a disclaimer here. There are some VPs of hospitals that have said to me personally that, Alex, I don't care what the IFP is. My concern is the patient. I
Yeah.
don't really care
Yep.
what it is that the manufacturer recommends to use on the bed or not. And to be honest with you, if the manufacturer doesn't allow me to use my disinfectant, that will be the last bed I buy from them, and I'll let them know.
Right.
So to me, that should be the attitude. It seems like, hospitals are customers when it comes to so many different manufacturers, and when it comes to beds or furniture, all of a sudden they cower and they panic and they get into like, oh my God, are we meeting the requirement that the manufacturer requires to clean the equipment? They should go back to the manufacturer and say, listen, this is the last bed we're ever buying from you, unless you can figure out a way to make a bed that meets the needs of my disinfectant. Because my concern is the patient. And right now, the C. diff outbreaking in my hospital, and I can't disinfect properly because you're requiring that I only use purple tops. Or I'm just, again, bringing it as an example.
Yeah.
But, you're just, requiring me to use, peracetic acid. And I can't use peracetic acid because nurses are complaining, that it smells like salad, or the vinegar is burning my eyes, or whatever it is, the chemical. Uh, you
Well,
know,
All those
you
IFUs should be written to chemistry and not brand names. That would solve the problem right
yeah,
there.
I would agree that I think that would be very helpful. But see, Dr. Jopp, in his 2-page letter, he talks about this being a big scope problem. So, uh, one is availability of the IFU. And he mentioned, I'm going to read right here. It says, rather than IP report on a variety of barriers that exist within the current IFU system, many of which involve the quality, complexity, difficulty, clarity, consistency, feasibility, availability of products, and availability of the IFUs themselves. So all of these are problems that he's noted to Joint Commission. So I mean, it's not just product alone. It's many different facets that it is a problem related to the IFUs and about being surveyed specific to IFU use.
Well, that is, I mean, to me, this is still a very strange world that we're dealing with, because he's right. Infection control nurses now all professionals have to now become experts on
Chemical
equipment in the
scientists.
hospital.
Chemical
No, chemical,
scientists.
they have to forget about chemical science. That would be easy enough. But now they got to be experts on the equipment that the hospital buys. They got
Yep.
to go through warranties. They got to go through the plastics and materials and analyze and argue with manufacturers whether they can use this or not use that, and when they can use it, and then maybe get involved with dwell times. How long can chemical be on the bed? I mean, you have to become a bed scientist rather than looking out for the welfare of the
Patient.
patients, and how we're
Yep.
cleaning and disinfecting the surfaces versus, the welfare of the beds. Again, this is an equipment. This is now, to me, something which the hospitals are at fault. Let me rephrase it. Not the hospitals, but the people in charge of buying the equipment in the hospitals should be the ones that are dictating to the manufacturers of beds unless there's one company that makes beds. I mean, I know they're not. I know there's a bunch of different manufacturers of beds and equipment, but one of the requirements should be is you want to bring your stuff into my hospital. I need to be able to clean it with anything I need to clean it with in order to make sure there's no germs. To me, very simple. It doesn't, when we buy toilet paper, hospital buys toilet paper or bags, they can dictate how thick they want that bag to be. And if it doesn't meet that requirement, they're not going to, buy it. The toilet paper's got to be a certain amount of ply, and it's got to be able to not clog up my toilets. You know what I mean? It's not like, well, the manufacturer says not to flush. What do you mean not to flush? It's toilet paper. Beds, equipment need to be disinfected with anything that the hospital throws at it that's commonly be used in the industry. And if you tell me it can't, well, then we won't buy it. Doesn't seem to work that way with equipment
Right.
for some reason.
Yeah, beds are a hot topic, but there's a lot of equipment in a hospital. I mean, we've got
Yeah.
pumps, we've got scopes, we've got
I mean, all of
all
that. I'm just
kinds of
saying it
things.
apply. I was using beds as an example, but it
Yeah,
should apply to
but
everything.
Yeah.
but
And hopefully, when they're looking at equipment in hospitals, infection prevention is invited to the table. And one of the questions I always asked when I was there at the table, how are we going to clean and disinfect this? I've
Right.
asked it more than one time. And I
yeah,
know IPs do ask that if they are present. And
Well,
sometimes
listen,
they
really,
don't.
guys.
Sometimes
I,
they don't get invited.
well, that's true too. And I think for the most part, the IP probably can tell you better how to clean and disinfect that piece of equipment probably than the manufacturer. Now, the
Right.
manufacturer may tell you
Right.
how to break
Oh
it
yeah, for
down.
sure.
Yeah.
Well, to me, it just seems that this letter is a great letter. I think it's a very important letter. I think that we need to, hospitals need to take control of, their
Patient
cleaning
care,
of equipment. Patient,
patient
that's the word.
care.
Look, thank you, Darryl. That's what I was thinking.
Yep.
Yeah,
Are the
and
hospitals,
I don't,
Alex, are the
yeah.
hospitals actually coming to you and saying we can't use your chemical because of what the manufacturers of the equipment are saying?
No, they
Well,
don't say they
Happening
can't. They
anywhere for
say
you?
no, no. They don't say they can't. What they'll do is they'll say to me, "Is it approved?" And I'm always, who cares? I have to. My chemicals are approved, but my question
They
that I'm
kill
always
germs. Yeah,
asking,
they kill germs.
yeah, I'm like, why all of a sudden, do I need approval from a warranty on a bed manufacturer that it can be used in the equipment? I would think the number one concern would be, is this thing cost efficient for the hospital from a lowering the HAIs, hospital acquired infections? Am I going to make the patient healthier? Am I going to make the environment healthier? Am I using a chemical that's not going to kill everyone on the floor, or long-term effects on the patients and the nurses and the staff especially, since they're using this on a regular basis? I would think that my number one concern would be the safety of my staff versus the bed and the IV pole. But that's not the question. That's not the question that people ask. The question people ask is the bed itself. Is the bed going to be safe? Is the IV pole going to be safe? To me, that should be the last question.
And that's what
is
And
it
they're asking.
gonna?
People actually come to you with that exact thing?
yeah,
They
yeah,
do, really? Oh,
they
wow.
do. They
Okay.
really do, which is crazy. Which is, I think it's only in the world of healthcare would something like that pop up as a question that shouldn't be
Doesn't
asked.
fit. It doesn't fit, really,
It
in a
doesn't
sense.
fit. From an infection control nurse, it doesn't fit. I can understand if engineering came to me and said to me, "Hey, Al,
Right.
is this going to destroy my beds?" And I may say to the guy, "Yeah, it's going to destroy your beds." And he'll go back to infection control and say, "Well, is this really worth it? Is this going to save lives? Is this going to be better than the disinfectant that's good for the bed?" Right? Then they can make that analysis. But I have infection control asking me about beds or IV poles, or glucometers. To me, our chemicals approved for all those different surfaces, but I'm always shocked. I'm always shocked, and I'm always thinking that if there is a chemical better than mine, or a chemical that's better than what's being used in the marketplace today, but it's not great for beds, does that mean that chemical is going to be pushed aside and lives are going to be lost as a result of a bed or an IV pole or a pump, because Joint Commission is telling the infection control nurse that, you know what, don't use the best disinfectant, use the second best disinfectant because it's better for our beds. I mean, hello, is the hospital treating beds or is it treating patients? To me,
That's
that's the whole
that's the issue.
discussion. Yeah,
Most hospitals now feel like, or they're being forced into cleaning and disinfecting for a warranty versus cleaning and disinfecting for infection prevention.
correct. And
Yeah.
that and to me, it's not only the patient that we're talking about, but it's also the staff that are cleaning the areas. What's safe for them? And that I think to me is again, this is mind-boggling, really mind-boggling. And I don't get it. And
Yeah, I
maybe
like to
this is
mess with
something.
your head, so that's why you invited me.
I got so many things messing my head. Another thing that's messing my head, I keep on thinking about the tsunami is about to hit Mike behind him on the beach there.
Yeah.
That's what, but
Well,
that's
it's a
only one
real
of the things messing with
concern,
my
and
head.
it's a real
Yeah,
concern, and I would
yeah,
appreciate anybody out there that might view our podcast. Reach out to Alex, reach out to someone. Let us know some of your thoughts on this
yeah.
and
That'd be
your
great.
thinking, because the more that we can talk about this issue, my goal is to help IP. I want to help IP do the best job for the patient. I can't control what manufacturers do. They're going to build equipment like they build equipment. But I think if we push back and say, "Hey, you're not clear. You're trying to cover for warranty. You're trying to do this. You're not for we got to have product that kills these bad guys, and we need that product." And they can't do it like you said, Alex. We need to look for other manufacturers, or manufacturers need to change their game, and they need to
Yes,
rewrite their IFUs to be more clear and concise, and not leave it as it's very confusing. It's
Very
very muddled
confusing.
and confusing. And
well, I'll tell you, if anyone, I like that idea, Darryl. If there's anyone else out there who listens to this, who has input to put into this discussion, maybe there's something that we're all missing here that someone out there has insight into, and would like to share with us in that audience of exactly what is so important about the IFUs. It would be great just to reach out. Hey, Ronnie, want to share your email? Maybe they can reach out to you,
Sure.
and then maybe you can have them on the show, or if they don't want to be on the show, they want to just have their comments read. We'll be very glad on the next episode to bring that up. So, Ronnie, share your information on this, and maybe Mike, when we
I'll
actually
put it up.
record this,
I'll put it up
we'll
there.
put it up there.
Yeah.
Go ahead, Ronnie, share it.
Yeah. It's Ronnie, RONNIE, at ACE, JAN.com. Ronnie at
And
acejan.com.
and Mike will have it on the website. So if anyone wants to comment or share some information for our next podcast, we'll be very happy to do that. In the meantime, I have to go catch a plane, and Mike has to go hit the beach. So
or the beach may hit
I
him.
didn't pick this background. It happened to be there when I turned it on. So
there you go.
Gentlemen, I appreciate the opportunity to
Thank you,
join you.
Daryl.
Thank you
Thank you
very
very much.
much.
Thank you
appreciate
all.
Appreciate
it,
it.
guys. Yeah.
Great. You
Be
bet.
good,
Thanks,
guys.
guys.
Right.
Take care.
Bye.
Bye bye.